you very much, Dr. Peter. This presentation has really been insightful, and I think for me, really, I have actually been to Kiwoko before, but still, just from your presentation, I have gotten a lot from it. For instance, it's actually a wonder that you've been in existence for 30 years, and when you say you started under a tree, and to look at where it has gone now, it's exciting to imagine where it's going to be in the next 20 years or the next 30 years from today. I particularly noted some of the things you were talking about, especially in regards to handling about 70,000 outpatients or an average of about 84 daily patients. And it kept resonating in my mind, and I'm thinking, okay, so if that has been what has been happening over the past few years, since we all know that 2020 got very tricky, 2020 had its own, it came with its own challenges, and biggest among them was COVID-19. So I'm just curious to know, and I think this is where the next speaker is going to come in from. How did COVID-19, how did it affect the flow of Kiwoko Hospital? Did it change in terms of increasing the number of patients? Did it change your CBHC activities? Did you have access to go to communities anymore? So just be very curious. And I believe most of us on this call right now are really curious to understand, how did COVID-19 affect Kiwoko Hospital, or even just health in the rural setting where you are? So I believe this is the part where really Dr. James can then get in on call and just share with us from the perspective, from the Kiwoko experience, how did COVID-19, affect Kiwoko Hospital? And as Dr. James, you're coming on, maybe I could just ask a question. I was doing a bit of reading earlier before this, and one of the common questions I keep finding online is we don't seem to know whether whether COVID directly affects a mother who's pregnant. If, let's say, a mother got COVID-19 and she was pregnant with a baby, does that directly affect them? So I'm hoping maybe Dr. James, these are some of the things that you're going to maybe share about as you come on call. Dr. James, the floor is all yours.
Thank you very much, Ronnie. I'll take my mask off for now. My name is James Nyonyintono, a doctor at Kiwoko Hospital. I'm a surgeon by training as well. And I am glad and would want to welcome everyone who has joined us on this webinar to try and see how COVID-19 has affected the healthcare system function at our hospital. I'll share a screen and take us through what we have observed. So when we were hearing about COVID-19, it was first a story going around the world, and we thought it was only in China. There are lots of myths about this. And so as the whole rest of the world was talking about COVID, we're hearing these things, we realized that being healthcare workers, we are frontline workers, and we are one of the few who were allowed to continue working as usual. But certainly, life was not the same. But as we heard about COVID-19 being a problem in the world and was spreading, we realized that we were part of the world system and we needed to prepare ourselves. So following the declaration of this as a pandemic by WHO, we right away from Feb 2020 decided to work on our strategies, and we constituted a technical working group to help us understand what COVID is all about and what it will take us, partnering with and many other individuals. We have been able to marshal up to this great challenge, and we had to redesign the flow of our patients, having only separate gates for both entry and exit. And we went through the routine, screening, the hygiene issues, spatial distancing, education, and making sure that everyone had the appropriate PPE for the task ahead. We initially felt and were told our mandate was just to screen, isolate, and refer, but gradually, as protocols have changed, we have taken on to testing and treatment for those that were able to be helped at our unit. Very important milestones. All of us know about 30th January and how that was declared a pandemic. But for Kiwoko, our first case was on the 2nd of August, who happened to be one of ours. And it's about 6 months after the first case was confirmed in Uganda. When we got our first case, we had to look for contacts, and we got 13 of these. They got some of them, all our patients got moved to Mulago Hospital and Entebbe Hospital. They were treated and they all recovered. This had a negative kickback on us because most of them were from one particular clinic. So we had to scale down on the services in that. But thankfully, 4 weeks later, the clinic was up and running as usual. When we had this first 13, we realized that we needed to understand what the status of everyone else in the hospital was and our immediate community. So we had mass testing. To date, Uganda has had more than 800,000 tests, and about nearly 40,000 have been positive, plus 325 deaths. Our parent district, Nakaseke district, has had 1,629, of which 81 tested positive. While at Kiwoko, we have tested 919, of which 54 were positive. Now, these 919 are part of the 1,629 by the district. We have had 4 deaths. Only about 2% of our staff ever tested positive for COVID, and I think this is very commendable. And testing has had a lot of challenges. We take the samples and deliver them to the Central Public Health Laboratory in Kampala or the Virus Research Institute in Entebbe. And there have been some challenges of late or missing results, and you go through the hassle of having to make a decision to retest. And sometimes the people have left or are not patient enough to wait for this. And transport has also been a big issue, having to ply the roads to take and bring results back. In all this, we have observed that service utilization has gone down. In fact, while doing the budget of 2020, we thought about an 80% performance budget. And this seems to tie in with the statistics we've seen over that year. And we are getting a new normal. Across the board, service delivery has gone on as usual. However, the utilization has reduced by even up to 22%. So you've seen fewer patients, we've had fewer deliveries, and we have also observed that patients have come in later than they should have, and therefore had a worse disease status. And some have had to stay longer in hospital, whereas others have stayed because they needed to get transport back or even to pay up their bills. However, we also noticed that our cesarean section rate went up by 5%. I know, like from the previous presentation, has been an average of 27, but gradually over time it has risen to 34% in 2019 and then to 39% in 2020. So this to us reflects that the people came, there were fewer coming, however, they needed more intervention than probably they would have. The other clinics have already been talked about, but similarly, we have observed a reduction in the service utilization. We know there was a lockdown, if you look at around March, and that brought the biggest drop. And then there were fears amongst people. They were not sure who was spreading what, and particularly COVID. So many opted to stay away from clinics. Transport was a problem. And I think the status of the economy was also affected negatively. And this being a paying hospital, they must have rearranged their priorities of spending. We went through a lot, but chief of this was to understand how to manage COVID. We went through months, literally months. We had at least an opportunity of 6 months before we got the first case, but we looked through all protocols by WHO, CDC, Ministry of Health, and everything else that was available to try and see how we can formulate protocols to support us at Kiwoko as we waited for Ministry of Health guidelines and some of the difficult aspects of COVID management. So we used whatever it took. We had to address the community, we had to talk to our staff, the patients coming. And we also went through the routine screening right at the entry. We have one entry at the hospital, And you go through screening, there are questions asked about COVID, there's temperature taking, and thereafter, the screening goes on with a specialized form for those who have had symptoms, and then we select those who need testing and those who need isolation, let alone referral. So we have had to change some clinics and extend the outdoor clinics because on the inside, space became a very big issue. Certainly for a condition like COVID, like others that we managed before, you would need to be dressed appropriately. So we have seen a change of the way we dress. Initially uncomfortable, they in fact had what we called a COVID ear. There were many sore ears from wearing masks, difficulty, and all sorts of challenges about PPEs. They can be very uncomfortable, particularly in the OR, in the operating room, where you have to be donned up if you had a COVID suspect or patient. And this can be very hot and uncomfortable. We to date have had a few scares or people suspected to have had COVID, but thankfully they turned out negative. The ones that we operated in OR. However, there have been at least 54 in our hospital, and unfortunately 4 of them passed. We referred most of them for further care. Hand washing, I think that's common to us, using hand rub or water and soap. Water and soap is the commonest and probably the cheapest, and we have this right from the entry to all entries of wards and service areas, and we encourage everybody to do hand washing. Space, very important. We always talk about safe distance, safe distance. We needed more space. Like we had not planned to have COVID when we were having our structures laid out. We had to resort to the use of tents to space out, and thankfully these came handy to help us increase on our available space. This was not only in the treatment areas, but also accommodation for our mothers. We needed to repurpose some of the areas we had. For example, our HIV outpatient clinic shed was repurposed to accommodate at least 20 mothers whose babies are in the newborn care unit. Our male ward had to be repurposed to be a respiratory ward, and we had to move many other clinics from their original places to create space and be sure that we are able to handle COVID. Our operating room, we needed more space, so we had to look for room elsewhere for working on mothers that are suspected or are confirmed to have COVID, or those who needed to have their delivery there, so that it shouldn't interfere very much with the routine flow of work. Certainly oxygen is a very key element in some of the patients that we had. And many of them would come to hospital because they are short of breath and oxygen is what they needed. So they would be screened through the protocol to see those that needed it. Concentrations from various donors became very handy. But like you might know, they don't deliver as much oxygen as might be needed. So we had to resort to cylinders, use of gas cylinders. Now, these can be difficult to manage. Now, we're very grateful that for those we found we could not manage, we linked up with the Ministry of Health, and there were pickups from the ambulances to come and take these further on to get the care that they needed. We want to work in a safe environment and make sure our patients are safe. But given the COVID situation, we run a risk of work overload or shortage, because once exposed, then you need to be away from work, or if you took ill from the disease. And also some staff would need time to care for their family in case they were not well. So we needed to be working out how are we going to handle this if it arose. So immediately we started getting people reskilled in the other units where they were not working, so that in case there was a shortage, they could easily be moved to those units and support. And there were requests for extra duty cover, as well as looking outside what we had for our establishment, locums to come and help us. We have reviewed the CDC guidelines on return to work, where when the worst comes to the worst, you could actually have a COVID healthcare worker who even has symptoms back to work. But there are guidelines as to where they could work and how that could be. It's quite scary. But if the worst came to the worst and services must continue, there is a way that can be handled. So our main observation has been that we needed partner support, and we had to reorganize ourselves in order to contain the situation. And we have observed that generally there has been a reduction in the service utilization. Maybe I could at this point answer the question of the moderator. There have been a few studies, the little I know, where they were debating to find out whether a mother could actually transmit COVID to their unborn child. But there was no conclusion to that. However, the main route is through the airway, and if the mother, for example, is coughing and spreading disease and is not covering their face with a face mask, there is a risk that they can transmit this to their newborn baby. So there have been different strategies to try and mitigate that, including at some point when necessary, especially if the mother is very unwell, separating the mother from child, but continuing to provide the milk because that is a very much needed feed for the child. So thank you very much.
Okay, thank you very, very much, Dr. James. I think it has been very insightful what you have shared. I particularly got interested in a number of things that you have said, and you mentioned something about the COVID year. It's really an issue I've had from my particular perspective, but it's been pretty interesting. I just wanted to inquire from you, Doctor, because we see even from here in Kampala, one of the biggest issues around COVID-19 is there's so many myths around it, you know. So everyone kind of seems to have a myth around COVID-19. And I just wanted to inquire from your perspective, from the rural perspective or from the rural health perspective, what were some of the key myths that you maybe had around COVID-19, and how did you as a Kiwoko Hospital fight these myths or combat them?
Thank you, moderator. Myths are quite many. The very first one that I ever heard was that this disease cannot affect Africans. And so it created a sense of safety, people feeling, oh, we are untouchable, we are okay. And then at some point, people continue to think they have a strong immunity. It's only for the elderly and those that are frail. Of course, we know they are affected worse than the much healthier younger people. And also people thinking that the young people don't get it, or if they do, they will not suffer as bad. Which is another myth that people have had. So generally speaking, even in the rural area, not very different from the town, there's a laxity of people wanting to adopt the preventive measures. They have all sorts of reasons. I've heard people complaining about breathlessness, and you know, anyone with anything on their face will feel a bit uncomfortable. However, the discomfort from the mask wearing can be mitigated and you get used to it, and that should save you from a worse happening if you got COVID. So in our own community, mask wearing is also a very big challenge. In fact, people think that when you wear a mask, you are the one that has the disease, and you'll be stigmatized thinking you actually want to spread it, so keep away from us. I remember one of our staff that went to one of the markets and was denied access because he was wearing a mask, and he was told, you have COVID, please do not come in here.
So in that situation, how then do you handle it?
So we encourage and continue to ensure that all our staff are showing a good example. Encourage them to wear their masks even in the community. When you come in a rural area, you may nearly tell who is a hospital worker from Kiwoko by seeing someone wearing a mask. The chance that the person you see wearing a mask in our rural area, that they are a staff of our hospital, is very, very high. And we encourage our staff to be leading and talking to people. We do educate those who come both in our unit as well as those who do not come in, but we have VHT teams and our community arm of healthcare provision does teach people on COVID, and we try to help the community to understand their need and role in the prevention of the spread of this disease. Some actually also learn from what they see. For example, when they see ambulances coming in and picking patients to take to another health unit, we take time to tell them, look, that is what it is, and it is here. So don't think it is not here. Do what it takes to make sure everybody is safe. And we also support them when they have discomfort from the wear of mask, like we talked about the COVID year. There are tricks that you could play You try and see how those loops don't cause pain behind your ears. And one of them could simply be making a knot on the loop of the mask, or even putting a rubber band at the back of your head that holds the loops. And that should be very helpful. And we have seen different designs of masks. There are those that are made that do not have loops that go around the ear. So all those have been very helpful in trying to help people to comply with the guidelines with the prevention of the COVID spread. Thank you.
Okay, thank you. I think it has really been powerful what you have said, and it's not lost on us from what we've been discussing that it has been really an uphill challenge. But from the discussion we're having here, we seem that you're actually managing it quite well, and we're actually really, really, really proud and happy of the kind of work that you are doing.